Hello everyone and welcome back to my channel. In today's video, we'll be exploring two common but distinct joint conditions, osteoarthritis and rheumatoid arthritis. We'll break down how they differ in terms of risk factors, symptoms, diagnosis, and management. By the end of this video, you'll have a clearer understanding of these two conditions and be able to recognize their key differences. Let's jump right in. Let's start with osteoarthritis, often abbreviated as OA. It's the most common form of arthritis and is generally considered a wear and tear disease of the joints. First, age and sex predilection. Males typically over 50 years old, females typically over 40 years old. Although it can occur in both genders, women tend to develop it at a younger age compared to men, especially after 40. Second, risk factors. Female gender, obesity, occupation-related repetitive injury or trauma, and genetics. Obesity and repetitive joint stress, like certain manual labor or sports, can speed up cartilage breakdown, leading to OA. Genetics can also play a significant role. Next, there are two types of osteoarthritis. 1. Primary OA, gradual, insidious onset, often associated with age-related wear and tear. 2. Secondary OA, develops following an injury or infection. Can happen at a younger age if there's a specific trigger. Morning stiffness, usually less than 30 minutes. Improves with movement and activity. In hip OA, stiffness may last under 1 hour. Stiffness duration may increase as the disease progresses. One hallmark of OA is that stiffness is relatively brief in the morning, and it tends to ease up as you get moving. Pain characteristics worsens with weight-bearing activities like climbing stairs, relieved by rest, crepitus. A crackling or grating sound may be present. Joint effusion, if present, is usually cool and not boggy. So if you notice pain that gets worse the more you're on your feet and better when you relax, that's a common OA pattern. Hand involvement commonly affects the one-stone carpometacarpal joint. Involves distal interphalangeal and proximal interphalangeal joints. Usually spares the metacarpophalangeal joints. A classic sign of OA in the hands are Heberden's nodes on the dips and Bouchard's nodes on the pips. Diagnosis, clinical exam plus radiographic evidence. Bone spurs osteophytes are the most specific radiographic finding. Joint space narrowing and subchondral cysts may also be seen. Diagnosis often involves X-rays showing those telltale bone spurs and narrowed joint space. Next, let's talk about rheumatoid arthritis, a chronic, systemic, inflammatory autoimmune disease characterized by fluctuations between remissions and flare-ups. Definition and epidemiology. Chronic, systemic, inflammatory autoimmune disease with spontaneous remissions and exacerbations typically begins between ages 20 to 50. Women are affected 2 to 3 times more often than men. There's also a juvenile RA form affecting children. So unlike OA, RA can strike at a younger age and tends to have a more aggressive inflammatory nature. Joint involvement primarily affects small joints. Most frequently involves PIP and MCP joints of the hands, spares the dips. Often progresses from asymmetrical to symmetrical involvement. Commonly involves wrists, shoulders, elbows, knees, ankles, and cervical spine. Usually spares the lumbar and thoracic spine. RA has a preference for certain joints, especially the knuckles MCP joints and the PIP joints in the fingers, while notably sparing the dip joints, which are often a site for OA. Morning stiffness lasts more than 1 hour, often several hours. Also occurs after periods of inactivity like prolonged sitting. If you experience prolonged morning stiffness that can last an hour or more, that's a red flag for RA. Clinical presentation: chronic polyarthritis with spongy, doughy, joint swelling and heat. Low-grade fever around 99 to 100 F during flare-ups. Pain and swelling often in 5 or more joints. Fatigue, malaise, and depression may even come before the joint symptoms. RA is systemic, so beyond just the joints, patients can feel fatigued and unwell in a more general sense. Systemic involvement cardiac, pericarditis, myocarditis, atherosclerosis leading cause of death in RA, pulmonary, pleurisy, pulmonary fibrosis, ocular, dry eyes sicca, Sjogren syndrome in 10 to 15% of RA patients, other Felty syndrome splenomegaly, leukopenia, recurrent infections. This systemic nature is what really sets RA apart. It's not just about the joints, it can affect many organ systems. Diagnostic tests. Rheumatoid factor positive in 70 to 80% of patients. Anti-CCP, anti-cyclic citrullonated peptide antibody test is more specific than RF. Elevated ESR, CRP, and imaging findings, alongside clinical presentation, also confirm diagnosis. Your doctor may run these blood tests if RA is suspected, and imaging can help assess joint damage. Medical management, DMARDs, disease-modifying anti-rheumatic drugs, e.g. methotrexate, NSAIDs for short-term pain relief. Coordination with a rheumatologist is essential. Early and aggressive treatment is crucial in RA to slow disease progression and prevent joint damage. Here are the key differences between OA and RA. 1. Cause and nature. OA, degenerative wear and tear. RA, autoimmune with significant inflammation. 2. Joint involvement. OA often affects weight-bearing joints, knees, hips, spine, as well as dips in the hands. RA frequently affects PIPs and MCPs in a symmetrical pattern, spares dips. 3. Morning stiffness. OA, less than 30 minutes, improves with activity. RA, more than 1 hour, can last several hours. 4. Systemic features. OA, primarily local joint involvement. RA can involve heart, lungs, eyes, and more. 5. Gender age. OA, males greater than 50, females greater than 40. Risk increases with age. RA, more common in younger adults 20 to 50, 2 to 3 times more common in women. And there you have it. The key aspects that differentiate osteoarthritis from rheumatoid arthritis. Thanks for watching this video. I hope it provided you with valuable insights and information to strengthen your preparation for the OCS exam. Keep reviewing, stay confident, and best of luck on your path to becoming an expert orthopedic clinical specialist.